I would like to thank the organisers for inviting me to speak in this symposium on management of diabetic somatic neuropathy. I'd like to talk about vitamins in diabetic neuropathy. What place? I'm Paul Fornelli, Scientific Director, Diabetes Research Centre, Qatar Biomedical Research Institute, Ahmad bin Khalifa University, Qatar Foundation, Doha, Qatar. The key question to address for this presentation is diabetic neuropathy, a complication of diabetes affecting over 50% of patients with diabetes without effective treatment. Can vitamins help? The most common patterns of nerve injury are distal symmetric polyneuropathy, radiculopathy, mononeuropathy, and autonomic neuropathy. The order of cell injury in diabetes in peripheral nervous system leading to symptoms of diabetic neuropathy is currently unknown. Studies of mishandling of vitamins in diabetes, including particular vitamins, increased renal clearance, increased degradation, and functional resistance, has led to the hypothesis that vitamin supplements, often at high dose, may have some therapeutic benefit for management of diabetic neuropathy. Vitamins considered in this presentation are shown in the table. Vitamin B1, thiamine, vitamin B6, pyridoxine, vitamin B12, cobalamin, vitamin C, ascorbic acid, vitamin D, and vitamin E, alpha-tocopherol. I give the daily reference intake, DRI. It is perhaps worthwhile giving this as a percentage of the total body pool of the vitamin, reflecting how quickly the total body pool may become depleted with decreased intake or availability. Note also that for many vitamins, the plasma half-life is much lower than the tissue half-life, indicating that once incorporated into tissues as active forms, vitamins are quite long-lived. But if there is increased renal clearance from plasma, vitamins may be susceptible to wash out from the body. Let's look first at vitamin B1, thiamine, and related supplements. The active vitamin is thiamine pyrophosphate, with dietary supplement usually being thiamine. High dose of thiamine treatment produces increased plasma thiamine, as indicated by data from the Lahore pilot thiamine diabetic nephropathy trial, showing a 10-fold increase in plasma thiamine. Oral thiamine at pharmaceutical doses, 100 to 300 milligrams, increase in plasma thiamine concentration by 4 to 10-fold in healthy people and patients with diabetes. This is evidence from our Lahore study and the pharmacokinetic studies of others shown on the right. One supplement related to thiamine that for a time appeared would offer a therapeutic advantage was benfotiamine. Benfotiamine is a benzylated derivative of thiamine monophosphate. Human metabolism has no use for thiamine monophosphate, so benfotiamine must be deesterified and dephosphorylated to thiamine and then pyrophosphorylated to the active form of thiamine pyrophosphate. Benfotiamine enters cells by the reduced folate carrier, RFC1. A minor metabolite of benfotiamine, S-benzylthiamine, is lipophilic, whereas benfotiamine itself is not. Most clinical trials of vitamin B1 for treatment of diabetic neuropathy have used benfotiamine. In the BDIP phase 2A study, 40 patients with type 1 or type 2 diabetes and symmetrical distal diabetic polyneuropathy were randomized to 4 times 100 milligrams per day benfotiamine or placebo treatment for 3 weeks. The endpoint was neuropathy score. This was improved with benfotiamine treatment and pain score was also decreased. In the BENDIP phase 3 study, 165 patients with type 1 or type 2 diabetes and symmetrical distal diabetic polyneuropathy were randomized to 3 times 100 or 200 milligrams benfotiamine or placebo treatment for 6 weeks. The endpoints were neuropathy symptom score and total symptom score. The outcome showed neuropathy symptom score improved in per protocol analysis when the randomization is lost, but not intention to treat analysis. So concerns were now emerging that benfotiamine supplementation may not be effective. Finally, in the long-term oral benfotiamine supplementation on peripheral nerve function study, 67 patients with type 1 diabetes with decreased peroneal and tibial nerve conduction velocity were randomized to 300 milligrams per day benfotiamine or placebo for 12 months. The endpoint was improvement in nerve conduction velocity, peroneal, tibial or sural. There was no significant effect on nerve conduction velocity, so it is not clear if there is any benefit from benfotiamine supplementation. Since these studies, concerns have been raised over loading of cells with thiamine monophosphate by benfotiamine to much higher levels than found normally. At high concentrations, thiamine monophosphate inhibits the formation of thiamine pyrophosphate and transport of thiamine pyrophosphate into mitochondria. One reason why some patients with diabetes may be at risk of thiamine deficiency is the reported increased clearance of thiamine in diabetes inversely associated with decreased plasma thiamine. We subsequently found this may be mediated by high glucose concentration-induced downregulation of thiamine transporters, THTR1 and THTR2, in renal proximal tubular epithelial cells. At this point, I thought we had found an important mechanism of thiamine depletion in diabetes and why thiamine supplements may be beneficial to patients with microvascular complications. The data on thiamine clearance increasing about 20-fold was from a study in the UK. We then did a study in Indonesia and found much lower increase in thiamine clearance, only 2 to 3-fold. So there are regional differences, maybe due to genetic and epigenetic differences of the impact of diabetes on renal clearance of thiamine and thereby susceptibility to thiamine deficiency. We explored the decreased uptake and retention of thiamine in the sciatic nerve in experimental diabetes. Using stable isotopically labeled thiamine, we were able to study uptake and release of thiamine from the sciatic nerve in healthy control and streptozotocin-induced diabetic rats. We constructed a physiologically based pharmacokinetic PBPK model of thiamine metabolism in experimental diabetes. As you can see, sciatic nerve of streptozotocin-induced diabetic rats has impaired uptake and retention of thiamine. So the peripheral nerve in diabetes may have decreased uptake and retention of thiamine and be at risk of thiamine deficiency. Now pyridoxine and B6 vitamins. The active vitamin is pyridoxal 5-phosphate and the dietary supplement is usually pyridoxine, which is converted to pyridoxal 5-phosphate. Pyridoxamine has also been proposed as a supplement and is also converted to pyridoxal 5-phosphate. The main route of catabolism of pyridoxal 5-phosphate is to pyridoxic acid. Pyridoxal 5-phosphate is a coenzyme for greater than 100 transaminases involved in amino acid metabolism. There are some old studies indicating decreased serum pyridoxal and pyridoxal 5-phosphate in diabetes. We found some evidence of increased degradation of B6 vitamins to pyridoxic acid in diabetes, that is, increased urinary excretion of pyridoxic acid, which correlated positively with glycemic control A1C and duration of diabetes. So patients with diabetes may benefit from supplements to make up for this, say 10 to 20 milligrams per day pyridoxine. There have been 2 small studies of pyridoxine supplementation in diabetic neuropathy without evidence of benefit. Doses of less than 500 milligrams per day pyridoxine are considered safe. Higher doses of pyridoxine have been linked to a sensory neuropathy. Now vitamin B12, cobalamin. Functional markers of vitamin B12 are levels of homocysteine in the cytosol and methylmalonic acid, MMA, in the mitochondria. The hypothesis of metabolic resistance to cobalamin was developed by Lawrence Solomon to reflect decreased functional activity of cobalamin, increased homocysteine and/or methylmalonic acid in the presence of a sufficiency of active cobalamin, called holotranscobalamin, holo-TC. By convention, vitamin B12 deficiency is present when holo-TC is less than 50 picomolar and methylmalonic acid is abnormally increased, greater than 270 nanomolar. In our study of patients with type 2 diabetes in Indonesia, we found there were 14% healthy controls and with vitamin B12 deficiency and a lower proportion, 7%, in patients with type 2 diabetes. In the study of diabetic patients in Indonesia, or ISIS study, we found patients with type 2 diabetes generally replete with whole OTC, but they remained abnormally increased homocysteine, consistent with cytosolic resistance to vitamin B12. In a recent intervention study where all patients had relatively low cobalamin, treatment with methylcobalamin, 1,000 micrograms per day for 1 year, about 400 times the RDI, produced beneficial responses against diabetic neuropathy, improved vibration perception threshold, improved neuropathy pain and quality of life scores, sural nerve conduction velocity and amplitude, and electrical skin conductance in feet. In a meta-analysis of studies of vitamin B12 supplementation of 363 patients reported in 2016, it was concluded that there was no evidence of benefit of vitamin B12 in diabetic neuropathy. Doses of vitamin B12 included in this analysis range from 2 to 250 micrograms per day. Finally, vitamins C, D, and E. For the effect of antioxidant vitamins, vitamin C and vitamin E, there is limited evidence of benefit on diabetic neuropathy, despite oxidative stress being considered as a key driver of microvascular complications of diabetes. For vitamin D, it was found that serum 25-hydroxyvitamin D was decreased in painful diabetic neuropathy, and in an open label study, single intramuscular injection of 600,000 international units, that's 1,000 times the RDI, vitamin D decreased neuropathy score, total pain score, and pain assessment by questionnaire. So, on vitamins in diabetic neuropathy, what place? My concluding remarks are convincing evidence that vitamin supplements are generally effective in preventing or alleviating symptoms of diabetic neuropathy is lacking. Vitamin supplements in diabetes are justified where there is evidence of deficiency or deficiency of action, suggested for vitamin B1, thiamine, increased renal clearance, B6 vitamins increased degradation, and vitamin B12 metabolic resistance and deficiency in some instances. Limited effectiveness of antioxidant vitamins are also found for other microvascular complications in the MicroHope trial, calls into question the oxidative stress hypothesis of vascular complications of diabetes. We likely have to refine our understanding of the drivers of diabetic neuropathy to improve therapeutic approaches. Finally, I thank all colleagues shown working with me in my research on diabetes, vascular complications of diabetes, and more recently COVID-19 in QBRI, Doha, Qatar. I also thank the Qatar Foundation for funding my research program, and I thank you for listening and your interest. Thank you.